Hello, and welcome to another session of the intensive update with board review in geriatrics and palliative medicine. My name is Carl Russo, and I'm an assistant professor at the Icahn School of Medicine at Mount Sinai. Today, I'll be speaking to you all about navigating family meetings. I have no financial disclosures. Some of the objectives that we will be covering today will be reviewing the role of family meeting in clinical practice, reflecting on common challenges confronted during family meetings, reviewing communication tools and how to effectively use them, tools like spikes, nurse statements, remap, ask, tell, ask, and by the end, we will develop a best practice roadmap to conduct family meetings. Let's start with a scenario. This is Mrs. F. She is an 87-year-old woman with end-stage dementia who was brought to the emergency room because of increased somnolence over 3 days. Her workup is indicative of sepsis, likely due to aspiration pneumonia. She quickly decompensates and is evaluated by the critical care team. Concerned she is too frail and may not fare well with aggressive interventions, the medical team speaks with the family and they agree to a DNR. I want you to think a little bit about this scenario. Think about the setting, think about the players, think about folks making decisions, think about even how decisions were made in that setting and whether or not values may have actually been unpacked. How do you think the family might remember this experience? How about the medical team? How might they describe this encounter? What could be done differently? And essentially for this session, we will really focus on that last question is what could be done differently, thinking about this particular scenario and communication that happens for it. One quote that I always remember when I think about communication skills in family meetings is this one from Maya Angelou that I think captures a lot about what we try to accomplish. At the end of the day, people won't remember what you said or did. They will remember how you made them feel. And what is really important in communication with patients and their families is that they feel heard. For most people, and research has showed that if they feel heard, they will get much better satisfaction from this encounter. So using the tools that we have in order to optimize that goal. So what's the role of communication skills, particularly in clinical practice? It can help establish rapport between patients, their families, and the medical team. It's also an opportunity for the medical team to stop and listen with purpose. We're often so busy with so many different priorities. This is a particular setting where we have to stop and do that, and that can be very impactful. It can facilitate understanding of complex medical conditions. A lot of things that we try to explain, really getting an opportunity to really break it down. It can help explore patients and their families, the values that they have. A lot of the times we don't really have another setting to do this. It can help convey empathy and provide necessary support, letting your patients know that you truly care. And overall, it helps promote patient-centered care, which is at the core of what we're trying to do. What are some common barriers that come up in communication? These are just a few of many, and we'll kind of go through some of them. Readiness is a big one. Whether a patient or their family feel that they're in a place where they're able to have this conversation and truly receive the news that you're trying to share. Time. We know that in our business, time is extremely limited. And finding time to actually sit down and have these conversations can be challenging. And the same way for families and patients, they have their lives outside of the hospital. And for them, time is also something that can be incredibly scarce. Understanding. People can come at the conversations at many different levels, and it can be challenging to navigate to make sure that you share a message that's heard in the same way by everyone. Relationships. We know that within families, relationships can look very differently, as well as relationships between the medical team and patients. Sometimes those can be strained, and it can be incredibly challenging to have a conversation in the context of these existing relationships. Agendas. It could be a family member trying to share their grievances about how the hospitalization has gone so far, whereas you're trying to get an approval for an emergent surgery. So really trying to align these agendas to the best you can to make sure that folks end up satisfied at the end of the conversation. Setting, we saw in a scenario before, the BZED probably is not the most comfortable or best environment to have this conversation, but we know that space, particularly a private space in a hospital, is extremely scarce. So thinking about where are you actually having these conversations? In culture, we know that folks come from a mosaic of backgrounds, and how we receive information and how we like to make decisions might not necessarily look the same. So really thinking about how culture may impact these conversations and your communication. Uncertainty. In medicine, there are so many few things that are actually exact, black and white. There's a lot of the gray, particularly when we deal with serious illness in older adults. So communicating uncertainty can be very challenging. And emotions. We know that these conversations, particularly the ones around bad news, can be high stakes. And as a result, emotions can come up. And how do you navigate these emotions so that they're heard, received, and you can eventually move forward with the conversation? And training. This one is particularly a clinician barrier. And very often we hear from so many different doctors that they don't have enough training to have these conversations. They don't have enough practice with these conversations. So really looking through how can we optimize these different factors. Moving on, we'll think about what good communication look like. In this particular example, it has so many of the barriers that we've talked about so far, and the sense that this is definitely not optimal communication. When we think about good communication, looking at the image to your right, it really kind of focuses at the core all the different components that factor in to making this a good and positive communication experience. Um, it is particularly patient-centered. It focuses on shared decision making and what you need in order to do that. Most of the surveys shows that it improved patient satisfaction. At the end of the conversation, patients and families are usually much more content, knowing that they feel heard. It may improve even symptoms, longstanding headache, depression, anxiety. Those actually might improve. There's a correlation with there. And it may also improve treatment adherence. If your patient trusts that you truly believe what their values are, then they will better focus on their treatment and stick to it. There are studies showing that communication is associated with fewer malpractice complaints and also reduced length of stay without necessarily having adverse impact on mortality. And that's really important to remember. So how do we start to overcome these communication barriers that we talked about a little bit earlier in order to make it a good communication? Well, we have these communication skills. They can be learned over time, but we know that those skills don't automatically improve without effort. It's an active process. Even though didactics like this one can be very helpful and they're not the most effective for assimilation. So really thinking about once you have the information and materials, how do you move beyond in order to build your own skills? And for that, we have interactive workshops. These have been shown to be the most likely modality to result in meaningful practice change and folks feeling confident in their communication skills. And most of all, in order to build good communication, and overcome these barriers, it requires intentional reflection, feedback, and practice. This last step is the one that is most often missed. For most clinicians, you're able to kind of get the practice in, get the tools, but having the opportunity to create intentional reflection, feedback, and practice is the one that we constantly face challenge with. Let's dive more a little bit into what's in our communication toolbox. In the next few slides, we'll cover tools such as spikes, ask, tell, ask, remap, and nursing statements. These are part of what you have in terms of your resources in order to optimize your communication. Let's begin with spikes. This is a very common one. I'm sure folks are familiar with it. It does cover the different components of what you would see as an overall roadmap to a family meeting. First, thinking about the setting. This is usually where you should spend most of your time. I often talk to folks, especially our learners, about if you do a good setting up of your meeting, the work that you're going to have to do within that is probably not going to be that much. So making sure that you think of all the different components that might impact that. Is it a private setting? Do you have all your key people? Is this going to be in person versus remote? Are there any interpreter needs? Do you have enough chairs for people in the room? Are there tissues there for folks in case they need them? And do you have the right amount of time allotment without having any disruptions? So all of those are just a few of the components that may actually make a very impactful change for your particular setting. Next, you want to think about perception. How do you know where to start? Do you know where folks are going to be coming from? So making it intentional to ask that question so you know exactly what information that you need to deliver. You can share sentences such as, what have other doctors told you about your illness? What's been shared with you so far? Kind of a broad, open-ended question to really give people the opportunity to let you know what information they have already. And next, you ask for an invitation, knowing that just because folks are here, we can't make the assumptions that they're ready to receive this information. So being intentional about asking, would it be okay for me to discuss whatever you want to? How do you prefer to receive medical information? That's another way that you can ask that question. And then you want to share your piece of knowledge. It's often good courtesy to give a warning shot, especially if you're going to be sharing bad news. It's important to remember not to use so much medical jargon, keep it really simple, and remember after to stop. Don't move on to the next thing. Don't make assumption. Just stop and watch for a reaction. And as you take that pause, you're next going to be communicating empathy. As I mentioned earlier, there's going to be potentially some emotions if you're sharing difficult news. So taking the time to really respond to these emotions, communicating empathy, and getting a sense of when folks are ready to move on to a next step and if they are. And finally, you do want to summarize. You want to review, you want to discuss next steps and create a follow-up plan. That really kind of helps wrap things up in a good way and helps indicate and give folks cues about what to expect next. The second tool that we often talk about is your Ask, Tell, Ask tool. This tool can first, with your initial ask, that's to check perception, just like we did earlier, gauge what the patient and their family already know. What have the doctors told you about X, Y, and Z? What is your understanding of your illness? Next, your tell will be your big headline. Remember, like before, keep it short, brief. You just want to give them the basic information and let them ask you questions so you can give details. The results show that the cancer is back. Unfortunately, he is dying. Then your last ask will be checking in to see how your information landed. You want to make sure that this information is being processed in an appropriate way before you move on to next steps. Is this news surprising to hear? How is this information sitting with you? Those are some good examples of how can you elicit that response. Third tool we'll take a look at is the remap tool. And that's really the one that helps shift the conversation from the initial content that you've shared in news and kind of start moving towards a direction to take action and make decisions. First, you want to reframe the conversation, talk about where you are and indicate that fork in the road. We're in a different place with your disease. Next, you want to, again, expect emotion. That is something that even if they heard the news before, folks may still have an emotional reaction to, and you want to respond to that with empathy. That will be through the last tool that we'll cover right after this slide, which will be nurse statements. And then next, you want to map values, keeping the patient at the center of what's happening and making them a priority. Try to elicit from them and the family what is most important to them. And also, as you look towards the future, what concerns you? That's another way of kind of asking that question so folks can actually respond. And as a next step, you want to align and hearing the information that you're receiving and knowing what options are available, you want to kind of put those things together and head towards a planning stage. As I listen to you, it sounds like the most important things are, and you kind of mirror that to the person based on what you've heard. And finally, you want to think about a plan. Um, and an example to do that could be, here's what we can do to meet your goals. Well, when we go through the roadmap in detail, we'll talk about a few other examples of ways that you can talk about a plan or a list one. And as our final tool, we're going to look at nurse statements. I'm sure folks are very familiar with those. And those are ways that you can communicate empathy, respond to emotions in a way that really captures exactly what the patient is trying to express. Um, you can name what you're seeing in front of you. It sounds like you're frustrated. What I usually recommend is, in those instances, to tone down the volume a little bit. It's okay to say it sounds like you're upset, sounds like you're angry. I probably wouldn't say it sounds like you're irate. So tone it down just a bit and let the patient and family adjust it if it's not appropriate. Most of the time, your aim is not to be accurate with what you're identifying. If they respond and correct you, that's even better information because they are sharing more about their emotions and you're getting more data. Next, you can think about understanding. And this is where we try to just get a better comprehension of where things are. Something after somebody shared, a patient or their family shared something pretty impactful, you could say, this helps me understand what you're thinking about. And that could be a way that you let them know that you're hearing them. Respect is something that is so another way to respond to some of these emotions. I can see you've done everything possible to fight this illness. So really honoring what they've done in effort in their journey and what they're sharing with you. Support and silence. Those can sound like, for example, our team will work to make sure you have what you need, letting the patient and the family know that they're not alone in this process. Silence is a particular one that I put there, and I figure we don't really use very often, and that's just the pause. So somebody sharing an emotion and just creating the space for that emotion to settle for a bit. That can be very impactful. Oftentimes I say, think about a pause that's anywhere between 8 to 10 seconds. That usually will feel like it's much longer. But for patients and families, that could be quite impactful and not feeling meeting our urge to occupy the space. And finally, thinking about explore. And this is where you're trying to look for a little bit more clarity. Could you tell me what you mean by, and kind of asking them a little bit more information about something that they said that you're having a difficult time understanding? So now that we've covered these different tools in the toolbox, we can talk a little bit about how to put those into practice. And knowing that you have your tools and when you're starting to practice, some of us in general can tend to lean towards using the things that are most comfortable. Maybe we have a natural skill at communication with patients and family and have ease to do that. And we've been doing it in the same way for many years. Or maybe we're absolutely alarmed and we do not like to talk to patients and their families. It's incredibly stressful and it's something we dread every single time. What's most important is to think about that learning edge, that learning zone, the yellow right in the middle, where you have enough discomfort so that you are growing, you're challenging yourself, but also not pushing yourself fully to the red where you're not going to get much benefit out of it. So thinking about the learning settings where we're doing this, and this is where the interactive workshops are particularly helpful because they will actually put you in a setting where it's not fully high stakes, like a true family, but it gives you that learning edge right there to be able to challenge yourself and really get that feedback, do that self-reflection, and continuing to practice. So now that we have these tools, now that we've talked about these concepts, let's take it back to the scenario. Remember Mrs. F, who's our 87-year-old with end-stage dementia in the emergency room, that loud emergency room, busy, and with the family that's probably very concerned, maybe she's scared. How might you approach a scenario differently? And here we'll kind of put all of what we've talked about so far into this roadmap that will start to look through a few different steps that'll incorporate everything in terms of communication skills and the concepts and really kind of help us move through this next stage. First, we'll talk about gathering for a pre-meet. This is again the setting, so the S part of your spikes tool. Things to remember before sitting with the family, get your team together, decide who will talk about what. Sometimes, for example, you may have specialists and they're able to come and talk about every single piece. Other time, for example, you have specialists that are not available. They're in an OR or in some sort of busy clinical task. Have you been able to gather the information and even ask basic questions that you can then relate to the family in this conversation? So really being intentional about how you strategize around that. Try to agree on some key points to address. Just because we're all in medicine and we're processing similar information, it doesn't mean that we're receiving it or we're identifying the same key points. So really being intentional about what it is that you want to outline. Sometimes that can be redundant, but being deliberate about doing that can make sure that there's less confusion and you're not trying to navigate that within the meeting itself. One particular example that comes to mind is prognosis. Many times, prognosis is something that is an inexact science, and maybe we have difference of opinions on what prognosis is for this particular patient. So making sure that in your conversation, in your pre-meet, everyone is on the same page about the information that will be shared. And also talk about contextual cues. What do you know about this family? What and the patient? What are their dynamics? Are there particular challenges that you're anticipating? Have there been previous family meetings? How have they responded in the past to bad news if you're aware of this? All the different key components that can really help in this process and really set you up for success. So some of the comments that you might use during this pre-meet and as you're gathering could be, could I propose a way to structure the meeting? Something else that you might say might be, when the meeting ends, what would be a constructive outcome? Additional important things that could be to uncover during this particular part of the conversation can be to think about who's going to be leading the conversation and when people are going to be jumping in, and even particular cues to let people know about the time for them to share their own information. Let's go to step number 2. And that will be introduce everyone and also introducing the agenda. That is particularly important, and sometimes it can take a lot of time. This is still part of your S part, your setting up of your spikes. It's important to make sure everyone is introduced, whether people come in the meeting at the beginning, in the middle of it. Sometimes patients and families can be quite distressed about another person just kind of like coming in and not knowing who's in the room. Sometimes medical teams can also be distressed about another family member coming in maybe after the meeting has started. So making it a point to even pause and make sure everyone's introduced. And then remember to minimize all the distractions that are happening to the best you can, with the understanding that you're not going to have control over everything. There are moments where it's going to be particularly challenging to navigate, and you're going to have to be flexible and adapt to some changes. Try not to overcommit, particularly with your agenda. Sometimes we want to accomplish many different things and we want to tell somebody about the beginning to the end of their cancer and the entire journey. Maybe that's not the best use of time. Think about that there will always be room for follow-up discussions. What are you trying to accomplish in this moment? I usually recommend, particularly around this time, to try and set anywhere between 1 to 3 agenda items at most, making sure that you negotiate with the family, because what you're coming in to discuss could be not align with what they're coming in to discuss. You want to have a goals of care meeting to talk about code status, whereas a family is in a place where they want to tell you about the bad time that they had in the emergency department and how long they had to wait for a bed. So really making sure that you get to navigate this so everyone feels that they have a space in order to be heard. Some examples of ways that you might communicate that could be, let's start with introduction. My name is Dr. So-and-so, and my role is XYZ. Another way that you might communicate this is, the purpose of this meeting is, and is there anything additional you would like us to cover? So really kind of opening it up to the family to make sure that they have an opportunity to add items to the agenda themselves. As a third step, we have explaining what is happening. That's where you're going to get to use your P, your I, and your K of your spikes. So checking for perception, asking for an invitation, sharing your piece of knowledge, and you're also your ask tool in order to do exactly that. You have to remember to assess for perception, particularly because, as we mentioned before, people can be coming from a few different settings. So don't make assumptions. And this is true, even if either the team tells you that they had this conversation already with the patient and their family, or you had a previous conversation with the patient and their family. It's never a given how people process information. So making sure that you make that intentional step of asking for perception is very important. Next, you want to encourage everyone to weigh in. Maybe there is a quiet family member in the corner who is really not saying much, or maybe there's a particularly engaging family member who is talking more and we're not getting more from the patient. So pausing and prompting and asking if the person who hasn't shared much wants to share anything themselves. Consider a warning shot when you're sharing information. This is true particularly when you're sharing bad news, giving folks about a heads up that the next few words or the next sentence might be very challenging to hear. As stated before, it's important to use simple language, avoid complicated medical jargon, and think about a headline. This is not the place for you to be displaying all of the wonderful, intricate medical knowledge that you've gained through medical school and all of medical training. This is the part where you need to make sure that you are understood. So keep it really simple and give people an opportunity to ask questions. One particular instance that I like to talk about for this is when there's another medical person as part of the patient and family. Sometimes it can be easy to lean into that and really start to kind of go back and forth and focus on medical jargon. I think it's important not to lose perspective about what you're here to accomplish in the room, and always think about stepping out with the person after, if they have particular and specific medical questions, that you can elaborate with them on a one-on-one basis. Some instances that can be really helpful, particularly at this stage, can be, tell me what you took away from this last conversation. Here's the most important piece of news. So really making sure that you tell them this is where you listen. The fourth step talks about empathizing with each person. This is where you're going to expect your emotions, both your E and your spikes and remap. And this is where your nurse statements are going to be the most impactful. So really making sure that you stop and acknowledge these emotions. A lot of times we want to move past those. Maybe you have a busy day. Maybe you have 5, 6 other patients that you need to see. Maybe you need to get to another family meeting. Things will not get accomplished until you take the moment to really acknowledge and address the emotions that are in front of you. And it's really important to do that. It's also important to open it up already to some of the other members of your team if you haven't done that already. Many of us work in interdisciplinary teams where we have extremely skilled folks who can elicit and respond to these emotions. And you don't have, if you're, for example, the conversation leader, you don't have to take it upon yourself to want to navigate that completely. You can lean on your team, lean on your folks in order to help navigate this conversation. And being realistic, oftentimes acknowledging emotions make people feel understood, and it helps in their process of kind of moving forward after they've taken information. Some sentences that might be helpful in this context can be, I can see you're concerned about It's impressive how much you've done to support. That's the respect one and the nurse statements. So really acknowledging what somebody may have shared with you about what the journey of the illness has been for them or even as a caregiver. The fifth step talks about highlighting the patient's voice. This is where you're going to do your M of your remap tool and really map somebody's values, getting a sense to make sure to prioritize the patient. They are at the focal point of all of this. And you do that by eliciting the patient's values and ways that you can do that through different synthesis could be what is most important to you. A lot of times for some families, it can be putting themselves in the patient's shoes, which is a little bit easier to do than making a decision from their own point of view, especially if the patient's not able to attend the conversation or is altered and can't participate. Some way to do that could say, for example, if grandma could speak, what do you think she would say in this moment? So really kind of pulling the person there and making the decision coming from their own perspective. Remember, in some cultures, uh, this is not how they make medical decisions. And even though we practice doing that, we think about it as a good standard of communication, that can be a very foreign concept to them. So really making sure that as you're doing this and opening it up, if you get a response that you weren't expecting, then ask yourself, is this culturally how this person makes decision, and do I have to readjust? Step 6 talks about planning for next steps. And this is where you are going to align as well as make a plan as these components of your remap tool and summarize as part of your spikes tool. If there is uncertainty in those moments, particularly if a patient, a family member has a difficulty making a decision, you can offer to recommend a plan. Would it be helpful if I recommended a plan? Patients and their families will most often accept the plan if they feel you are honoring their values. So really making sure that they are at the focus of this and you've really followed what they want. And remember to always summarize and check in. Based on what you shared, option 1, doing this amputation seems like it's best aligned with your wishes. So really focusing on what they're telling you, putting it together, and then bringing it. Some of the best practice, particularly for summarizing at the end of this conversation, is bringing back the essential point. So what we've talked about so far is over the next days, we will be focusing on, and you kind of enumerate these different components. And the last step will be reflecting post-meeting. This is the one that we often don't do. And although it happens quite often in an academic setting, I think it's something that's impactful for all levels of communication in a clinical setting, especially if they are, as long as there are other members, part of the team in there, it's important to debrief with your team and create space for everyone to share their insight. Very often, people might have learned or seen something very differently than you did, particularly if you were the one speaking a lot more. It could have been things that were missed. So making sure that everyone gets to share their insight as part of being in this conversation. It's also the way to learn. And it's also where you can receive some feedback. Maybe you did something that you noticed didn't land that you didn't notice landed particularly well, or did not land well. And folks as part of your team can really kind of share this information and help your growth and building and your communication skills building journey. It's important to document who was present, what was discussed, any insight gained, and what decisions were made. Ways that you can potentially open that up could be, what did we learn as part of this conversation? What did we learn from this family? And really kind of letting people jump in with their thoughts. And one important question to think about at the end of this is, how do you know if the family meeting was successful? And for many different situations or many different teams, that can look very differently. But I think focusing on these different components, just like the question that you had asked at the pre-mate, how, when this conversation ends, how will we know that this was successful? It's kind of like reverting it back to this and making sure that these points have been particularly addressed. So now that we've put all of this together, you have your roadmap essentially to navigate the family meeting, but also having these communication skills and also thinking about the context. And most importantly, thinking about practicing all of this together. So what are some of the take-home points? The first one is communication tools are an essential resource that can strengthen the therapeutic relationship with patients and their families. As we've seen in so many different examples, it can be very impactful. And it can have ways that it decreases particular symptoms. It helps with like lowering litigation and all these different processes. So making sure that you do that very intentionally with patients and their families. The next point is communication skills and their conversation roadmaps are key components for effective communication and clinical care. You need those tools in order to be able to do that work and communicate. So really being conscious about what they are and also starting to practice them. And which leads us to the third take-home point, which is building communication skills requires intentional reflection, feedback, and practice. Remember, it's an active process, and the more you put into it is the more you will get out. And with this, it brings us to the end of our lecture. Next, I'll be going over two questions that we can do together. Our first question: you are paged to the emergency department to consult on a patient with newly diagnosed metastatic colon cancer. He expresses anger at the fact that the surgery resident abruptly told him he most likely has advanced colon cancer after reviewing his imaging. Patient satisfaction with clinician communication has been correlated with which of the following outcomes? A, increased litigation. B, increased mortality in the hospital. D, decreased anxiety. C, decreased anxiety. D, increased length of stay in the hospital. I'll give you a few seconds for that. We'll be moving on to our answer. And if you said C, decreased anxiety, you have the right answer. When patients and families feel that their physicians are communicating clearly, they are less likely to be anxious, less likely to sue for medical errors, and have a shorter length of stay in the hospital without any increased mortality. It's not that it increases it, it's not that it decreases it. Most of the time, it doesn't really have an impact on mortality. Hence C being the correct answer. Let's move on to question number 2. A 68-year-old Spanish-speaking man is admitted with end-stage renal disease. You're consulted for goals of care regarding initiation of dialysis. You've heard that in his community, patients often prefer not to know their diagnoses. You ask an initial question about his understanding of the medical situation, and he says, "My legs got big because there's water in them." The most appropriate next step would be A, tell him you want to talk about his disease, but would prefer his wife to present with him. B, ask permission to explain the details of his medical situation. C, contact his wife to discuss his medical situation and establish a plan of care. D, inform him of the medical situation. E, use an explorer statement to further impact his understanding of his illness. And I'll give you a few seconds. All right, we'll go on to the answers. And if you chose E, that is the correct answer. Oftentimes, more than one question is needed to assess understanding. His answer may be a simplified way of explaining his complex medical problem. It's best to ask for clarification before assuming he does not have enough insight. Hence, E is the best answer. A and D both assume that he wants to hear the information without first exploring his preferences. B is also a good answer, but it does not explore his preferences before giving the information. This gives the patient less opportunity to control the situation. And C assumes the patient does not want to hear the information based on generalizations made from his cultural background. With that, we wrap up. These are my resources, and I want to thank you for your attention as part of this session. And I have my email here in case anyone would like to reach me directly. Thank you very much.